We welcome you to this session. We want to start. I would request our keynote speaker to take a seat on the dais, please. Professor Nuzul, would you come and join me here, please? Our first speaker will be Dr. Maziba Rahman Chaudhary. Her topic is starting ICL surgery in your own practice. Dr. Maziba, please. Audiovisual, would you look into this, please?
Screen. Fix the screen. Can you see the screen? Okay, fine. Respected delegates, a very good afternoon to you all. So ICL as a whole, it's not as popular as the other refractive surgeries. So in my presentation, I'm going to say that how I incorporated ICL in my practice. ICL is a phakic intraocular lens. I'll be specifically talking about the posterior chamber one because that's the most commonly used and that's what I have been using. And where is it placed? It's placed right behind the iris with the haptics resting on the ciliary sulcus. What powers are available? Myopia, it can correct up to 20 diopter with astigmatism up to 6 diopter. And the newer ICL, this is new, that it can even correct hyperopia up to 10 diopter with astigmatism 6 diopter. So let's have a look at the candidates who are suitable for ICL. Those patients who have very high refractive power or they have a thin cornea and are not suitable for LASIK or the K value is too steep or too flat, these are the patients that can go for ICL. Age is around 21 to 45, we'll keep it to that, and the refraction has to be stable for 1 year. And no other ocular pathology would be better. So once we have selected our candidates, we'll go for the preoperative assessment. We need to do a complete ophthalmological assessment, which includes an uncorrected and best corrected visual acuity. We'll have both the manifest and cycloplegic refraction, slit lamp examination. IOP measurement is important because if it's high, we would avoid ICL. And two things which is more important is the angle evaluation because we need an open angle for ICL. And also in the fundus, we need to check the periphery for any lesion and correct it before going for the ICL surgery. So an array of investigation has to be done. That is the corneal topography, biometry, endothelial cell count, and the last two, that is the most important, is the anterior chamber depth. It should be, for the starters, should be about 3 mm. But once you have in the habitude of using ICL, it can go down to 2.8. But ACD is important, and the next is the white to white measurement. I use the digital caliper to measure the white to white, and you can cross-check this value with the ILMaster or the Pentacam white to white. And now we also have the UBM, although most centers don't have it, and this directly measures the sulcus to sulcus measurement. Now ACD and white to white, why is it so important? Because this will determine the size of the ICL and will determine the vaulting. So what is the vault? As we can see here, that it is the distance between the ICL and the anterior capsule of the lens. So this distance should be about 500 microns, and the range is from 250 to 750 microns. What happens is, if it's undersized, what will happen? It will touch the anterior capsule, leading to a cataract, and it's oversized. What will happen? It will push on the iris, the angle will be closed, leading to a raised IOP. That's why the vaulting is so much of importance. Once we have done our investigation, what we'll do is just put in the data in the calculator given, And then we get a map like this. As we can see here, that this my patient had a refractive error of -11, but his corneal thickness was 520. So I didn't go for LASIK. I opted for an ICL instead. Once the measurements are done, we'll go for the surgery. In the surgery, I'll emphasize on two things. At first, when we are starting, please have someone who has done it before with you, or have the company people be there. Why? Because the loading is a bit different. At first, we fill the cartridge with two things, that is the BSS and the viscoelastics. And this is the bottle for the ICL. This is a very, very soft, thin lens. And there is no second one. So we have to be very careful not to damage it. With the soft tip plunger, take it out, put it in the cartridge, and now we make sure that the center is right at the center. Then we take the holding forceps, and this is a front-loading lens, so we slowly pull it towards the tip in position. So again, I want to emphasize that since there's only one lens coming, so we have to give some more time and do it very safely. Once this is done, we'll put it in the injector, and we are ready to put the lens in the eye. As I was saying, that toric ICL is also present. So before going in, we mark it, do the side ports, put in some viscoelastics, and then make the main incision to deliver the ICL. The second important one was the loading, and this is the delivery of the lens. Over here, we will also take 1 extra minute. Why? Because the position of the ICL is very important. If it goes upside down in the eye, what happens? We have to take it out again. We can't rotate it. So be very, very careful. Take an extra minute, slowly, gently push it in, let it unfold. Once it has unfolded and you have seen that, yes, it is in the right direction, only then fully implant the ICL. So over here, this is a real-time video. I'm just saying that I'm taking an extra minute to see that the anatomical position is correct. So once it's there, we'll take in and put the haptics under the iris, one by one. So again, over here, what happens is that the crystalline lens is there, the cornea is there, so we cannot have any damage to those. So we'll just do it gently and put the ICL in position. So number 1 has gone in. This is number 2 is going in. At first go, yes, it didn't go in, so I do it gently again and let it enter. Then comes the third one, the haptic is in. And lastly, the fourth one. But only with implantation surgery is non-over. I don't want a raised IOP the next day. So a proper visco wash is very, very important. And post-operatively, what we do is check the status of the cornea. We check the vault. In the first step, we just do the slit lamp examination, check the vault, check the IOP, and the positioning of the toric IOL. So it has some advantage of a clearless exchanges that I'm not disturbing the vitreous. So there's less chance of any retinal pathology. And over corneal laser procedure, the advantage is that very high refractive errors can be corrected. Now, the thing is that we should have all the surgeries in our bag when we are refractive surgeries. Why? So that we can give the patient the best treatment that he deserves. With this, I'll end my presentation. Thank you, AIOS, for the opportunity.
Any question from the delegate? Dr. Maziba, if unfortunately it unfolds in the opposite direction, what should you do? What should be your suggestion?
Thank you. So that's very unfortunate because we can the lens inside, and it might damage the cornea or the lens. So what do is, we take it out again, then again load it and put it back in. But when we do that, we have to be again extra careful because there's only one lens available. But it's possible to do it.
Okay. And this is a costly lens. Do you have any experience with the regional industry?
Yes, since I'm from Bangladesh, so this is the most expensive one. And another one is the IPCL that's been produced in India. We used to get it beforehand, but for the last 2 years, due to the COVID situation, the supply is a bit less. But when it comes, definitely it will be helpful to our patients.
Thank you very much for your wonderful presentation. Our next speaker will be Management of Cataract with Small People. Dr. Ashraf, please.
So, respected delegates, good afternoon. So, the managing the cataract with small pupil. So, what we need to do for the successful management, we need to have the proper pre-operative evaluation, intraoperative situation assessment, iris tissue properties evaluation, and definitely the most important part, the surgeon skill. Why the surgeon skill is important, I am coming to the next. So, first of all, the pre-operative evaluation, we need to assess why my pupil is small. It is due to old age, the patient has diabetes or use of drugs or any pseudoexfoliation syndrome or any uveitis or what. So after that, the intraoperative causes are very important because the prolonged surgery time, the iris touch manipulation, prolapse, or the fluid dynamics, my phaco machine parameter is also important here. So I don't do phaco with the proper parameter and I'm complaining, oh no, patient's pupil is not reacting, it should not be done. And now the pupil is small, so what I need to do? So we can do the pharmacological dilatation. It could be done the preoperatively and postoperatively with the OVDs, with multiple incision at pupil or manual stretching and devices. So, but when the pupil is cut or stressed, the thing is that there is a more inflammatory mediator released and not always the pupil is returned to its normal position. The patient is complaining photophobia or there is some cosmetic blemish after the surgery. So I personally don't prefer it. Rather than use the device, there are lots of devices available. There are iris hook, B-hex ring, Malaysian ring, and the pupil expander. Though we are from Bangladesh, we are most commonly using the iris hook as what we're doing after staining the capsule. And fill the anterior chamber and below the iris with OVD and do 4 small paracenteses at 2, 4, 8, 10 o'clock near the limbus. Hooks are inserted with for avoiding the touch of the endothelium and the capsule. And what we can also do, keep one additional hook can be placed under the main incision to allow the ease instrument entry. Then after the IOL implantation, we can remove the hooks. So we complete the small pupil surgery with the iris hooks. And I show the 4 hooks insertion, and sometimes we can assess the situation and just go for 1 hook and complete the surgery. So every time 4 hooks is the traditional part. If I think that I am confident enough and the patient's eye is supporting that we can complete it with 1 hook, just I need the proper visibility what I am doing. And also the Malaysian ring, it has the 4 scrolls to fixed with iris that expands pupil from 6 to 7 millimeter and gives us advantage not to doing the extra paracentesis. But when I am pulling it out, I need to make the caution that my endothelium is not touched, so I can do a support of the hook that it will not touch the endothelium. And we can also use the Visitech iRig pupil expander. I took this video with the permission of our keynote speaker, Professor Nazrul Islam. This is also a good expander device and it helps us to do surgery. And also the B-hex ring. The B-hex ring, this is the very good and the cost-effective ring invented by Dr. Suvan Bhattacharya. And it is also user-friendly. So these are the devices we can take help when we are doing the surgery with the small pupil. But one thing, the cataract with small pupil, are the device always required? I told the surgeon skill, the patient situation, intraoperative situation, that are the situation that we might not use the device to do the small pupil. So if we have the plan, we do the proper incision and use the proper OBDs, decrease the fluid parameters, and the chop techniques in the nucleus management, and using the bimanual irrigation aspiration, we have the proper plan in cataract surgery. We don't need to use the device always. And we're talking about the phaco, but in SICS, we can easily do the small pupil and even in heart cataract through the SICS. And here the SICS, the rhexis is beneath the iris, and we just prolapse the lens and explant it. So when we do phaco, the rhexis, we can plan for a few steps. The rhexis is the most important, and the surgery become easier without device if we can do the rhexis. And sometimes we can make the iris guard with the Kuglen hook and see the rhexis margin, and we can do the rhexis below the iris and complete the rhexis properly. And the nucleus management, we need to have the complete hydrodissection and the rotation. We always prefer the chop technique, complete division of the nucleus, and emulsify at the center of the anterior chamber with stable phaco probe, because I cannot see, I only see the center portion. So my phaco probe need to be stable and emulsify the nucleus, and use of viscoelastics as needed are very important. For the irrigation and aspiration, I always told that bimanual irrigation aspiration is very useful. Using the irrigation can give us the visualization what we need, and we can aspirate the nucleus. And in IOL implantation, I always say for the small pupil, go through in-AC implantation, not wound-assisted implantation. And we always check that my IOL is placed in the bag by just pulling the iris with the ball dialer, that the capsule margin is, I can see the capsule margin. And we also can do the toric IOL with the small pupil, like the premium IOL. Just here, we do the IOL implantation with the small pupil and made the proper axis. And definitely after first POD, the toric IOL axis was there. And so for the cataract management in small pupil, this is the planning for the surgeon. The surgeon have to have the plan A, plan B, plan C, and any of the plan could be changed in the intraoperative situation. So the most important is the proper preoperative history and evaluation. That is the most important part. If I feel that with small people, majority of the people have the IFIS, so better to use the devices. Planning the surgery, and if though I am not using the devices, keep the device ready at your operation theater, that if you need device at any time of your surgery, you can use it. So that is the thing. So how we can manage the small pupil. And thank you, All India Ophthalmological Society, for inviting us from Bangladesh to be here. Thank you.
Thank you, Dr. Ashraf. That was an excellent presentation. So, delegates, if you have any question.
May I ask one question?
Please.
Thank you, Dr. Ashraf. Brilliant presentation on sport management. I have a question. Frequently, we get the tamsulosin patient for the benign enlargement prostate. How do you manage this patient? How do you counsel this patient?
Thank you, sir. Basically, when the patient is getting tamsulosin, stopping the drug doesn't help. This is the experience. So the thing is that if the patient is continuing, better to stop it for a few days. But the thing is that we must to counsel the patient. This is very important, that the surgery might need longer time than the usual time, and we might use some devices to make it visualize and properly implant the IOL site. And we also think that there could be the IFIS there, and we need to have the operation room ready, that we will manage this patient and we will manage this pupil with my phaco parameter, my staffs, and my instruments, keeping it ready.
Thank you. I think in addition, what I do, I take the goniometry of the patient. If the angle is not narrow, I prescribe atropine eye drop for 3-4 days. And that most of the time it finds at least 5 to 6 millimeter dilated pupil, and most of the time we can do phaco if it is more than 5 millimeter. And the cataract is not very hard. So that I do regularly. Thank you.
Thank you, sir. That's a very good advice.
Thank you very much, Ashraf. Our next speaker is selective laser trabeculoplasty. Is it the first choice? Dr. Vasawati Shoha, Shahu, right? So, ma'am, thank you. Please, over to you.
Thank you very much. First of all, I'd like to thank the organizers of AIOC for giving me an opportunity to share glaucoma in this forum of around the world. So the topic for today, which I'll be covering, is selective laser trabeculoplasty, and this has definitely caused a paradigm shift in my clinical practice. So selective laser trabeculoplasty, is it your first choice? I have nil financials to disclose. When we talk of glaucoma, the aim of treatment is to preserve the residual vision while achieving the best quality of life. And quality of life today plays a very important role in glaucoma management. The only modifiable risk factors in glaucoma is intraocular pressure. So our main target is to reduce the intraocular pressure. And currently, how do we do it? If we see the current modality of treatment in most of the clinical practice is medical management. So we start with the one drug, which is the prostaglandin analog. If we have failed to achieve the target intraocular pressure, we go on to either add or switch to another treatment, then add in a third line of drug, and trabeculoplasty forms usually the fourth line of treatment. Now, we have to consider certain factors in any kind of treatment. So is the therapy sufficient? Is it sustainable? Is it tolerable? And is it affordable? So when we think of medical management, the most important barrier to therapy is adherence. And the factors may be multifactorial. We have old patients who often have cognitive and impairment, so they are unable to put in the drops. We have the socioeconomic factors in developing country where the glaucoma drops are usually very costly. In developed country, because of the long wait period, continuity in care is a big problem. And then we should not forget the side effects of the glaucoma drop. Now, if we see this patient is a patient who has been using prostaglandin analogs in one eye. So would you be happy with this look if you had glaucoma and was prescribed some drops? Well, I would not. So that's the reason we have to think of other options when we are managing glaucoma today. So while moving to laser, just let's take a peek look at the past of laser. So the initial trial with laser was using goniopuncture with a ruby laser, which produced a temporary lowering of intraocular pressure. In the 90s, Weiss and Witter in 79 were the first one to introduce argon laser. And they were able to achieve a lower intraocular pressure, but the effect was short-term. So what Anderson and Paris came up with is the concept of selective photothermolysis, and this has since then changed the entire thinking or thought process about laser. Now, what is selective photothermolysis? It states that it is a phenomenon which needs two important things. One, there has to be a intracellular chromophore in the target tissue, which is the trabecular meshwork here. That target tissue should have a greater optic absorption at the laser wavelength as compared to the surrounding tissue. Secondly, the duration of laser should be less than the thermal relaxation time of the tissue. So now with argon, the first point was achieved, which means the melanin pigment in the trabecular meshwork causes a selective absorption of this laser. However, the laser time of the argon laser was 0.1 second, which was much longer than the thermal relaxation time of the melanin pigment, which is 1 microsecond. And this was the problem which led to laser-induced burns, the formation of peripheral anterior synechia, and it did not show a success in ALT when the procedure was repeated. So the adverse effects of ALT or argon laser was related to this thermal effect. So there were very high acute IOP spikes following the procedures. There were formation peripheral anterior synechia, which causes the effect of laser to wear off. There were damage to the corneal endothelium. There was severe inflammation, and the glaucoma surgeons found that the chances of encapsulation of bleb following trabeculectomy in these patients was almost threefold higher. So that shifted the main idea of laser into another laser, which was selective laser trabeculoplasty, and this was invented by Latina and Park in 1995. Now with SLT, the 2 points of the selective photothermolysis was taken care, and that is why the side effects of the laser or the collateral damage was minimum, and it got the FDA approval in 2001. So when the histopathological studies were done in patients using argon and the selective laser trabeculoplasty, it was seen the selective laser trabeculoplasty mostly acts by inducing biological changes by increasing the gene expression and cytokine production, and did not cause much of structural damage as compared to the argon laser. Hence, it was a repeatable procedure. So there are certain predictors of success in SLT. The higher the baseline intraocular pressure, the better is the response, which means if a patient comes to us with a very high pressure, we expect a more or a better result in that patient following a selective laser trabeculoplasty. Secondary, higher the trabecular pigmentation, better is the response. And that's why selective laser trabeculoplasty works very good in pigmentary glaucoma. Also, there were studies which showed that if the patient has had a positive response in one eye, the chances of the other eye getting a positive response was much higher. So the conventional SLT is done by using, all you need is the SLT machine. These days we have the Duo machine with the YAG laser. So all you need is a separate lens. So we can proceed either 180 or 360 degree with a power of 0.8 millijoules, and we look at the champagne bubbles and expecting it to be present 50% of the time. The adverse effects are very minimal, except for some elevated IOP or minimal inflammation. Usually, I have not come across any of the other things. Now, we did a clinical audit at our place over 1 year. We have enrolled different types of glaucoma, and the intraocular pressure was seen a reduction of 72.95%. Also, there was a reduction in the number of drops. Almost 56.9% of patients showed a reduction of 1 drop, and 37.39% showed a reduction of 2 drops. Now, what has changed the entire or provided a leading edge to selective laser trabeculoplasty is the LIGHT trial. LIGHT stands for Laser in Glaucoma and Ocular Hypertension. This is a randomized controlled trial which compared medical management versus SLT, keeping into consideration the quality of life questionnaire. Although there was not much difference in the primary outcome based on the questionnaire, what this trial showed us that 74.2% of the patients who underwent SLT reached the target intraocular pressure and were drop-free at 36 months, which I feel is very encouraging. Also, this means there were 5 times less medication drop-related adverse effects. The COAST trial, or the Clarifying the Optimal Application of SLT Therapy, is the new ongoing trial which is trying to further reduce the power of the SLT. So it is a study which is comparing the conventional SLT with COAST SLT, wherein you repeat the patients every year with a very minimal dose of 0.3 millijoules, whereas in the conventional you start with 0.8 millijoules. So this concept is devised from our retina colleagues who undergo the Avastin like PRN and treatment and extend principle. So this is basically based on that. It's still ongoing, but the initial results have been very encouraging. So to conclude, SLT is an effective option to reduce intraocular pressure with minimal adverse effects. It preserves visual fields with a good quality of life. It's cost-effective, more tolerant with no ocular surface problems, and it is a repeatable procedure. So if anybody asks me, is it your first choice, rather than asking why, my question would be, why not? Thank you all for your kind attention.
Thank you, Dr. Shahu. That's a wonderful presentation. And thank you for flying over all the way from New Zealand.
Thank
It's
you.
great to have you here. Any question, delegates from Johan? Yes, please go ahead.
So with the permission of Chair, and Dr. Shah, thank you very much for the SLT presentation. Actually, I agree also that SLT is the first choice for the primary open angle glaucoma, even in the secondary pseudophakic glaucoma, if it is open angle. As you are working in New Zealand, right?
Yes.
So I think it will be different than Bangladesh, India, the power energy. Because in my country, we use 0.9, sometimes 1.0. But maybe the white people, they need a less. Another question to you, that you have shown 180 to 360 degree. Actually, what is the routine procedure? You do 180 degree or 360 degree in all your cases?
Thank you for your question. Now, there are two parts of the question. Let's move on to the first. In fact, the white people, they need more energy because the trabecular pigmentation is fainter in there. So if you see, if the trabecular pigment is more, the power needed is less. And that is what, in pigmentary glaucoma, we might be able to achieve a champagne bubble at 0.3, 0.4, whereas in a normal glaucoma in white patients, so we need a lesser power, a higher power. So in Indian eyes, in fact, when the trabecular meshwork is very pigmented, we should be able to get away with a lower power. Now the second thing is, mostly because for us, there is a long wait period. So I go for bilateral 360-degree treatment in the same sitting.
Okay.
And that has not shown any kind of adverse effect as of now. The only thing which we get is the IOP spikes.
Yeah.
But if it is a pigmentary glaucoma patient, there I need to be careful because I know these are the patients who present with a very high IOP spikes or the inflammation is high. So there I would want to do 180 degree in one sittings and then go for, like in the next sitting, do the next 180 degree. But studies have shown there is no difference between the two. So it's basically an individual choice and depends on what setting you're working at.
Thank you. I have another quick question. What is the post-operative follow-up about the treatment? What do you give?
So initially, like after doing the laser, we make the patient sit for an hour to record any kind of IOP spikes. If there is no IOP spikes, I just give NSAIDs for 10 days, and that's about it.
NSAID, not a steroid?
No.
Yeah.
Look, the studies have shown that either steroids or NSAIDs can be given. They have equal results. But with steroids, there is always a chance of we don't know which patient is a steroid responder. So
Yeah.
I usually avoid the steroid. We give NSAIDs for all patients. And if the pressure, because these days I just don't do SLT only in mild glaucoma, I do SLT in all patients as the first choice. So my intraocular pressure depends on the target pressure of that patient. Let's say the patient is already on 4 drugs and I have done an SLT. So I will do NSAIDs for 10 days. I will reduce the patient drops by 2 drops, not all the 4, 2 drops, and usually see after 4 to 6 weeks. 4 to 6 weeks is the usual response of the SLT to be seen. There are few of the patients who are late responders who can respond up to 8 weeks as well.
Thank you.
So
thank
6 to 8 weeks is the time.
Dr. Shahu, thank you very much, and safe journey back home.
Thank you.
Okay. Our next speaker is from Bangladesh. His topic is how to handle nuclear drop. By the way, he has handled one of my case last week. Welcome, Dr. Bilal Hussain. Over to you, please.
Thank you, sir. Respected Chairman and dear delegates, Assalamu alaikum and good afternoon. I'm Dr. Bilal Hussain. Welcome you all to our today's presentation regarding how to handle NUCLEUS drop. I'm extremely grateful to AIOS and especially Dr. Parthu Bishar sir for giving the opportunity to participate in this conference, DreamCon. So first I will share this case. This is a case presented to us with severe pain and dimness of vision. He had a history of cataract surgery 2 years back, followed by a good vision for 4 to 6 days, followed by profound loss of vision. So after initial empirically, we have managed the case. When the media has become a bit clear, then we have found there is a drop of 3 to 4 pieces of nuclear matter in the vitreous cavity, which causes intractable high rise of intraocular pressure, followed by desmoid cell also. And this case was managed by the persona vitrectomy. And after the vitrectomy of 2 weeks, then the patient becomes settled, normal intraocular pressure, clear cornea. So such kind of nucleus drop is not uncommon, though unexpected, and it is maybe the sequelae of eventful cataract surgery due to posterior capsular tear or zonular lysis or traumatic. So in this case, the nucleus drop was detected a bit later. So then this case was managed by anterior vitrectomy, followed by cleaning of the cortical matter from the capsular bag for better visualization. And after confirming the anterior vitrectomy, which was followed by the core vitrectomy also, so nucleus was dropped over the macular region. So first the nucleus should be free from the surrounding vitreous.
Can you please reduce the volume of the video, the audio, please?
Then PFCL was introduced just behind the nucleus. As this nucleus was a bit softer, so he used the vitrectomy cutter to manage that drop nucleus. So after removing the all portion of the nuclear matter, then we have removed carefully the PFCL. In case of any vitreoretinal surgery, it is important to induce a posterior vitreous detachment for long-term safety. So for PVD, we have used the TA. So along the support of the TA, PVD was infused, and the IOL was implanted later on. Sometimes, after dropping of the nucleus, the nuclear matter becomes so hard or remains so hard that it is not possible to remove the nucleus with the vitreous cutter. And the ideal grammatical way is to manage the nuclear matter, the use of fragmatome. So again, first, the nucleus will be free from the surrounding vitreous, followed by induction of PFCL just behind the nucleus. Then fragmatome was used to emulsify the nucleus. As the same procedure of phacoemulsification, with the fragmatome, nucleus was emulsified. And as the fragmatome uses the moderate power and high vacuum, so it is very important to remove all surrounding vitreous along the nuclear matter. Even with the fragmatome, when we have removed the main portion of the nucleus, the teeny remnant or a smaller part of the nuclear matter may be removed by the cutter, because scattering effect of this nuclear matter may injure the retina, especially macular region. Sometimes if the nucleus is not so hard and fragmatome not available, then we can go for the suction removal. So with the high vacuum with the vitrectomy cutter, it may expel out to the main portion of the wound also. There is an extreme one difficult situation where there is a nucleus drop with retinal detachment. Here you can see there is a large retinal break at the periphery with nucleus drop and retinal detachment. So after removing the few amount of subretinal fluid, when there is a space, we induce the PFCL just under the nucleus. And in such cases, usually this nucleus remain a bit softer, that can be managed with vitrectomy cutter only. So we have described that PVD is a very important issue in case of nuclear drop management. So when doing the PVD, periphery should be checked to identify any retinal break in the periphery, and that should be managed accordingly. This case was managed by the nucleus drop without PFCL, and such kind of nucleus drop management can induce injury to the macular region. Ultimately, though the case was managed, but there is a irreparable damage at the papillomacular bundle, which causes the dimness of the vision. So, important message is that regarding the scenario, VR surgeon should be informed, and before removing the drop nucleus, it will be free from the vitreous. PFCL should be used judiciously, and PVD we have to induce safely. And definitely I prefer to go for barrage laser. Thank you so much.
Thank you, Dr. Bilal, for a wonderful presentation. And you people are for the anterior segment surgeon like us. And sometimes we fish around, we try to do it ourselves. What is your advice to the phacosurgeon in general, that when should we stop and refer this patient to the retina specialist? Dr. Bilal, please.
Thank you, sir, for very nice question. Actually, for prevention of the dropping of the nucleus, pre-operative evaluation is very essential. If there is any suspected probability to injure the posterior capsule, like posterior polar cataract, or there is any previous zonular dehiscence, so with all the precaution, we can proceed for phacoemulsification surgery. In such cases, sometimes we may should not be proceed for phaco, which may be managed by the secondary IOL followed by secondary IOL. But before we can even go for the ICC, is more than the zonular dehiscence 180 or more.
Thank you, Dr. Bilal Hussain, for your wonderful presentation. Now, the next speaker is Dr. Nazrul Islam. He is a keynote speaker, and his subject is glaucoma from retinal diseases. Glaucoma from retinal diseases. Over to you, please. Would you see that connection, please, again?
Connection. At the outset, I'd like to thank the All India Ophthalmology Society, especially the Chairman Scientific Committee.
Look into the connection again, please.
Dr. Partha Biswas. I think there's some connection problem. You can use my pen drive also. Here, the other computer. Okay. Yeah, you see. This one. No, not this one. This one. Yeah. So can I ask one question? How many of you are glaucoma specialists here? Okay. Anyone? So do you get glaucoma from the retinal pathology? I think many. So that is my topics actually. As a glaucoma surgeon, I find many patients, they come from retina colleagues. So I'm again thankful to Dr. Partha Biswas who invited for this presentation. And the topics is glaucoma from retinal disease or pathology, how we deal it as a glaucoma specialist. Next. Not going. One slide is not progressing. Okay. So we know that retina and glaucoma specialists work together side by side because many patients, they come from retina and many patients also go from us to retina. So if you look, that glaucoma specialists have this kind of complication after their surgery, like choroidal detachment, ocular decompression, retinopathy, hemorrhage, hypertonic maculopathy, malignant glaucoma, vitreous hemorrhage. All these conditions, we refer the patient to our retina colleague. On the other hand, similarly, our colleagues send many patients with higher intraocular pressure and glaucoma, like RD surgery with scleral buckle, pars plana vitrectomy, intravitreal gas injection, silicone oil injection, intravitreal steroid injection, complications from retinal ischemia. Dr. Billal is here. He is a retina specialist. I think he understands. He agrees that we get this kind of patient from them. Now, Dr. Niroj Kumar et al. Found in a study that what are the percentage of RD surgery and glaucoma. It is about, you can see here, 4.4%. Pars plana vitrectomy may produce up to 20% of glaucoma. Silicone oil injection can produce 4.8 to 48%. Intravitreal gas injection up to 20%. Intravitreal steroid injection can produce 79% of glaucoma, 11 to 79%. So let us see the retina surgery with scleral buckle. The retina surgeon, they give this buckle to make against the sclera to relieve the traction of the retinal tear and also for the facilitate the resolution of the subretinal fluid. But what happens? They also mechanically close the angle, the anterior chamber. That's why there is higher intraocular pressure. So in this case, we cannot do the laser iridotomy. That will not help. Rather, we can do laser iridoroplasty. Along with the medical management and topical corticosteroids, cycloplasics, and of course, medical management. But ultimately, majority of our patients do not relieve the intraocular pressure. So we have to go for surgical treatment. And you see, many patients need trabeculectomy, but trabeculectomy has a poor success, up to 53%, up to 5 years survival. So glaucoma drainage device is the answer, having better success rate up to 80%. So let us see a case with a scleral buckle after the retinal detachment surgery. Then you can see the buckle here. And I asked the retina colleague that, shall I remove the buckle? He said it is done only few months, so we cannot remove. So what to do? We put the Ahmed glaucoma bulb just behind the buckle and suture it with the sclera. So fortunately, the patient did very well after the Ahmed glaucoma valve implant, the high intraocular pressure after retinal surgery. Again, the pars plana vitrectomy, PPV, is most common surgery done by the retina surgeon nowadays. But it still may have the glaucoma, especially if the tamponade is gas or silicone oil. And treatment is medical management first. If it does not work, then you can go for the glaucoma surgery like trabeculectomy. And majority time it doesn't work, so you have to go the Ahmed glaucoma bulb or the Barbell bulb or the RD produced in India from Orolab is really nice implant to do. Intravitreal gas injection sometimes cause the higher intraocular pressure, and AGM, anti-glaucoma medication, usually control the pressure, and laser iridotomy actually works better because the gas is deposited behind the iris in the inferiorly. So definitely, if you do a laser inferiorly, it works and helps in the decrease of intraocular pressure. Silicone oil injection is again commonly used. Nowadays, less commonly, but previously it was more. It also produces high intraocular pressure. and up to 48% is possible. And again, in this patient, the anti-glaucoma medication doesn't work much. You need to do surgical treatment, especially the glaucoma drainage devices. Intravitreal steroid injection, the retina people, when they find the macular edema from diabetic retinopathy, uveitis, retinal vascular occlusions, choroidal neovascularization, post-cataract surgery, sometimes they use the intravitreal steroid. And if the patient is a steroid responder, definitely there is a possibility of glaucoma. And the percentage is 11 to 79%. So a lot of people, they suffer. And most important treatment is stop the steroid if possible. If not, then you can use the less potent steroid for the high IOP. As Dr. Shao presented here, these are the cases SLT works better. And light study also found that if your intraocular pressure is higher after the steroid responder, you can do SLT, it comes down. And even after 4 to 6 months, you may not use any glaucoma medication. The patient's structural function becomes better, and physiologically, people do better without any medication even. Now, finally, retinal ischemia is very big subject. You can see hundreds of causes. The retina doctor will understand hundreds of causes that causes retinal ischemia, and from the retinal ischemia may produce the neovascular glaucoma. And we know the pathology, retinal ischemia, release of angiotensin factor, produces the new vessels in the iris, in the angle, and produces the neovascular glaucoma. Different stages are there: pre-rubeosis, rubeosis, open angle, and angle closure. Actually, after the invention of the intravitreal bevacizumab, ranibizumab, the management became very easy, because with this injection, the new vessels comes down, resolution is there, and after that you can put the laser, you can do any surgery, especially the valve surgery. The results are really better nowadays. You can see in this patient, after the injection, the rubeosity has gone, the patient doing better. Open angle glaucoma is the stage where we should start invention, because from here, reversible position is possible. Even 6S vision is possible. But if you go to the angle closure glaucoma, then it is really difficult to do the reverse of the condition, because this is the stage where the pressure is, most of the time we get 50, 60, 70, like that, and angle is closed. Even you do give the intravitreal bevacizumab or ranibizumab, and you cannot release the pus. So vision is really poor in these cases. And though you have to treat comprehensive treatment, not the only glaucoma, you have to treat the patient, his diabetes or her diabetes, if it's uveitis, treat all these things medically. Then, of course, anti-glaucoma medication, except the PG analogs and pilocarpine. These are not indicated in the neovascular glaucoma, especially in the angle closure in inflammatory stage. So you can do both surgery, but you see here the surgery trabeculectomy result is not good, up to 61%. But during the trabeculectomy, we make a modified trabeculectomy utilizing the higher concentration of MMC and long exposure time. And I do a larger flap for this kind of patient, so that there is larger opening of the trabeculectomy, and ultimately the chance of cure, possibility of decrease in intraocular pressure is better. Lastly, I'll tell the tube shunts is the choice for the neovascular glaucoma, because most of the trabeculectomy actually it fails. So whenever you put a tube, most of the time we get good result, and you can see here, but the modification is there. People are using, I also use the MMC, the collagen matrix during the bulb implantation, because routinely we don't do it, but in this sort of cases, if you utilize the antimetabolites MMC or 5-FU or the collagen matrix, the results are better. Cycloablation is reserved for those cases who cannot see well, painful blind eye. We can do the endoscopic cycloprotocoagulation or transescalar cycloprotocoagulation. So in conclusions, I would say glaucoma from retinal pathology is not uncommon. With early diagnosis, it can be successfully treated by medical or laser or surgical treatment. Neovascular glaucoma from retinal pathology is a potentially blinding disease. Aggressive, comprehensive management with anti-VEGF, anti-glaucoma medication, laser and surgical treatment with control of high intraocular pressure and the underlying etiology is crucial to minimize the visual loss. Though This is refractory glaucoma, but with due treatment, it is possible to give back the vision to the patient. Thank you very much.
Thank you, Professor Nazrul. Thank you. We are encroaching in the next session. I would request all the speakers to come over on the dais for a photograph. Thank you.